So let's take it away. Good morning, guys. Happy to be with you today. We will be talking about ovarian 6 cord-stromal tumors. I have nothing to disclose. Let us start by saying that this PowerPoint will be saved on your Google Drive, in your GynPath library. You can always come back to this presentation. We are recording the lecture, and I will post the lecture online as well. Feel free to ask questions in the chat or just interrupt the discussion or raise your hand or anything. This shouldn't be a formal presentation. We need to interact as much as possible. The slides, all the slides that you will see in this presentation are already scanned in ProShare, your virtual study set. So please make the effort to go to the digitized slides and look at these examples. Hopefully now after the lecture, you will be more able to sort out your differential diagnosis. My learning objectives today is to focus on classification of 6 cord-stromal tumors. I will use a lot of morphologic features, both macroscopic and microscopic, to understand the classification and to try to build differential diagnoses. We will also talk about ancillary testing, IHC, and molecular as they apply to our differential diagnosis. So this lecture will be very focused on H&E and morphology. I will not talk much about the clinical aspects, and I will not talk much about therapy, but we will focus on morphology here. We will start by an embryologic introduction that helps us with classification. We will talk a little bit about intraoperative consultation, and then we will dive into the pathology review of all the entities in this category. Let's start with the introduction. This is a famous diagram from Blaustein, and it just shows that in the embryology, this is the urogenital ridge, and the surface mesoderm starts to invade into the undifferentiated gonad, and they start to form what we call 6 cord. The 6 cord in the female is diffuse. These are the theca cells and the granulosa cells. If this gonad becomes a testicle, the 6 cord becomes tubular, which is the seminiferous tubules. So that is the source of the 6 cord-stromal elements in the gonads. Of course, the second source of tissue is the primitive germ cells that migrate from the yolk sac to the gonad, and these will be the ova. And then the third tissue in the ovary is the surface coelomic epithelium, differentiate into what we know as the Mullerian duct, and the Mullerian duct will give you the surface of the ovary. So the ovary has 3 types of tissues that are driven embryologically from 3 different sources. So when you look at the ovary, the surface epithelium is from the Mullerian duct, which is driven from the coelomic epithelium. And then the stroma and the 6 cord, the granulosa cells inside, are driven from the mesoderm, and the primordial follicles will have ova that came from the yolk sac. And this is the microscopic counterpart. We are all familiar with granulosa cells. Outside the granulosa cells, this is the maturing follicle. Outside, you have theca cells. So theca cells and granulosa cells, these represent the 6 cord elements that invaded the gonad. Again, this is a table to summarize the 3 sources, the 3 types of tissues you see in the ovary. and the source of each. I'm not going to talk about the surface epithelium and the epithelial tumors today. I'm not going to talk about germ cell tumors, but this lecture is focused on this category, which is the 6 cord-stromal category. Microscopically, as I said, you have diffuse cells. These are the theca cells. And then there is a rim of granulosa cells. Granulosa cells and theca cells are 6 cord cells. And then in the center, you got the ova. As the primordial follicle matures, you start to see the Graafian follicle. And here's a high power field to show you granulosa cells and theca cells. So remember, theca cells and the fibroblasts out there, these are the stromal cells. Granulosa cells here, these are the 6 cord cells. The line between 6 cord and stromal, i.e. between granulosa cells and theca cells, actually has a basement membrane. And this is the only location in the human body where a basement membrane separates stroma from stroma. We know that basement membrane in human body separates epithelium from stroma, but this is the one location where it separates stroma from stroma, because the germ cells are essentially, the 6 cord cells are essentially stroma. So these are the different types of tumors. We talked about surface epithelium. We talked about germ cells. We will address that next week. But this week we are focusing on 6 cord-stromal tumors that represent between 2 to 3% of all ovarian tumors. So when I'm dealing with this at the microscope, my head is working in 2 highways at the same time. And I want you, throughout this presentation on 6 cord-stromal tumors, to always ask yourself these 2 parallel questions. Am I dealing with a 6 cord-stromal tumor, or am I dealing with a carcinoma? So that is the first differential diagnosis. Those of you who signed out with me, they heard me say many times, don't order a stain unless you have a question. So what is the question in your mind right now? The question on my mind, I'm looking at a tumor, I'm trying to decide, is it 6 cord-stromal tumor or is it a carcinoma? So this is one line of thinking. And then the other line, which is parallel to that, is that if it is 6 cord-stromal, so is it 6 cord or stromal? I.e., is it 6 cord from here or stromal from here? So that is the next line of thinking. Is it 6 cord-stromal or carcinoma? Then at the same time, I'm asking myself, is it 6 cord or is it stroma? If I decided that it is not a carcinoma. Let us start with intraoperative consultation. So the intraoperative consultation philosophy, again, for those of you who worked with me, remember that the purpose of the frozen section is to answer the question on the surgeon's mind, to help them with the next step in surgery, just the next step. If you can help the surgeon with the next step in surgery, then you did your intraoperative consultation. It is not the time to provide comprehensive diagnosis. So I am on a frozen section. I am not expected to come down to the specific diagnosis of the entity. If I can just answer the one question on the surgeon's mind, what to do next? That's what the surgeon is asking you. What should I do next? So I will try to focus my answer to that relevant question on the surgeon's mind. And the goal is to be as safe as possible. Of course, when we say safe as possible, I'm talking about being safe to the patient, not safe to yourself. You see, some pathologists intraoperatively, they want to be safe. They want to be safe. They don't want to be wrong. So you may give an answer that is vague because you don't want to be wrong, but that's not the right approach, because that's not going to help the surgeon. You want to be as specific as possible to answer the question on the surgeon's mind, but you want to be safe for the patient. So I cannot answer the question unless I know what are the options, right? So here's the gynecologist. The gynecologist starts with doing a cystectomy. You receive an ovarian cyst or you receive an entire ovary. So that is what you receive. Now you are going to do a frozen section. You need to understand what are the options available for the surgeon at this time. These are the options. The surgeon is going to do hysterectomy based on your diagnosis. They will remove the other ovary. They do tumor debulking. They may do staging or they do appendectomy. All of that depends on the words that will come out of your mouth. So these are the options. So if I say anything that has the word mucinous, that means that I'm telling them, take the appendix out and examine the rest of the bowel. If I say anything primary malignant, anything primary malignant will trigger a hysterectomy and a contralateral oophorectomy. If I specifically say low-grade or high-grade serous carcinoma and they see tumor, they will do tumor debulking and they will remove the large lymph node that appear grossly abnormal to them. That's not the focus of today's discussion, so I'm not going to go down there. So now here's the map before you. Now you see what are the options for the surgeon. So my answers during the intraoperative consultation has to address these issues. So here you are, you have a 3.7 centimeter ovarian mass removed from a 58-year-old patient. Here's the mass, cut surface, white. You see it's fascicular. There are no areas of hemorrhage. There is no necrosis. You do a frozen section and the frozen section looks like this. Homogeneous proliferating cells. What should be your diagnosis? So I'm asking myself the two questions. What am I dealing with? Am I dealing with a 6 cord-stromal tumor or a carcinoma? And if it is a 6 cord-stromal tumor, is it 6 cord or stromal? Can you answer these two questions? You get high power, you see more proliferating cells, no really mitosis. Even if you see a couple of mitoses, what would be your diagnosis here? I think we all will agree that my diagnosis should be negative for malignancy, favor fibroma, period. You are not supposed to say anything else. If you say these words, negative for malignancy, what's going to happen? What's going to happen is that the whole thing stops here. They remove the ovary. You told them it's benign. They will not go down this list. So that's just one example of a scenario that involves 6 cord-stromal tumors, which is a very different scenario from this one on the right. If the tumor looked like that, what is the difference between the one on the left and the one on the right? The one on the right, I have cells that are more, the nuclei are more round. They are trying to form round structures. I see some cords. So that probably looks more like a 6 cord. That's more like a granulosa cell tumor. So the one on the left is a fibroma. The one on the right is a granulosa cell tumor. So I will say this is a granulosa cell tumor. This is, I favor 6 cord tumor, favor granulosa cell tumor. What will they do with the diagnosis of granulosa cell tumor? Now you took them down here because granulosa cell tumor, as we will discuss now, will be treated as if it is a malignant tumor, and probably granulosa cell diagnosis will trigger a hysterectomy and a contralateral oophorectomy, or even some of our surgeons will do lymphadenectomy. So I hope I demonstrated to you how critical it is to differentiate between 6 cord and stromal. Because if you tried to be clever and looked at the one on the left and just called it 6 cord stromal, you left the surgeon wondering, is it 6-cord or stromal? And if it was just a fibroma, they may think they heard you say 6-cord, i.e. granulosa cell tumor, and therefore they may in fact do the hysterectomy. So the term 6-cord stromal tumor is not recommended on frozen section. You have to be either negative for malignancy, or you can go as far as saying granulosa cell tumor, as we will see now. Let us talk about morphology. This is the WHO classification of 6-cord stromal tumor. This is the table that will stick with you. This is the table that I hope you can print in your head, because this is our constitution, at least for today, and for ovarian tumors. You can see that 6-cord stromal tumors could be pure stromal. In this category, it is fibroma or thecoma. We talked about that category. There is a category called luteinized thecoma. Luteinized thecoma is a very special tumor that is typically associated with sclerosing peritonitis, a fatal condition that involves that affects young women. In our history here in Minnesota, we had 2 cases, 2 examples of these cases, and you are welcome to look them up. During frozen section, I did the frozen section for both of them. And during frozen section, the surgeon actually told me this patient has a plastered peritoneum. The peritoneum is just like a mass of fibrous tissue, which is the sclerosing peritonitis. And they gave me the ovarian tumor. So the diagnosis was not problematic. It looked like a luteinized thecoma, which explains the sclerosing peritonitis. Other tumors in this category, completely benign, sclerosing stromal tumors, microcystic stromal tumor, signet ring stromal tumor, Leydig cell tumor, steroid tumor, and fibrosarcoma. Fibrosarcoma is like the unicorn of 6-cord stromal tumors. It's in the WHO book, and I have never seen it. I never made the diagnosis, and frankly, I don't think it exists. It's an entity, but I warn of making the diagnosis of fibrosarcoma in the ovary for many reasons beyond the scope of this discussion. But when you look at a thecoma or fibroma, just because it has few mitotic figures, it doesn't make it fibrosarcoma. That's my point. So as far as we are concerned for this discussion today, pure stromal tumors are all benign tumors. And I emphasize that because this diagnosis will be managed by salpingectomy or salpingo-oophorectomy surgery only. Once you go into the 6-cord category, that will trigger, as I said, more extensive surgery because they treat them aggressively, because they behave aggressively. Remember, 6-cord, when I said the mesoderm infiltrates into the stroma of the gonad, those cells could be in a male gonad or a female gonad. So these cells have the capacity, when they become neoplastic, to differentiate into the female line or the male line. That is why in the 6-cord stroma, in 6-cord tumors, you can have granulosa cell tumor, in which cells differentiated into the female differentiation or the juvenile version, or you can have Sertoli cell tumor or Sertoli-Leydig cell tumor. So Sertoli-Leydig or Sertoli, remember, these are 6-cord tumors that differentiate along the male line of differentiation. We have a rare tumor here called 6-cord stromal tumor with annular tubules, SCTAT for short. I will show you an example. And we have one very rare tumor here called gyneandroblastoma. Gyneandroblastoma is an example of a tumor that differentiated into both male and female at the same time. So if you can picture a tumor that looks partly as granulosa cell tumor and partly as Sertoli-Leydig cell tumor together in the same tumor, that would be a gynandroblastoma. We don't have an example to show you of that, but I will show you examples of everything else. As I said, the pathologist challenge is when you deal with 6 cord tumors, you need to realize that granulosa cell tumors and some sertoli-Leydig cell tumors can be aggressive. They recur. They will definitely recur. Once a patient gets a diagnosis of a granulosa cell tumor, that means that she will recur, no matter how long she is disease-free. And that is why these tumors are treated very aggressively. The challenge for you is that morphology of these tumors is so diverse. They can take so many different pictures. How are you going to land, hopefully, on the correct diagnosis every time? That is the burden on you, to separate them from each other, because management will be very different. Once you give a diagnosis of granulosa cell or sertoli-Leydig cell, that is a very different management from other 6 cord or stromal tumors. In other words, your biggest challenge is to differentiate between granulosa cell tumor and thecoma and fibroma. Unfortunately, when we give these presentations, when we give lectures, we always, as you expect of me today, is to present you with classic examples. So to you, you are sitting listening now to me and say, how can I mix granulosa cell tumor with thecoma? These are 2 different tumors. You showed me they are morphologically very different. Yes, but I showed you the very classic examples, or I will show you classic examples. But just remember, in your head, differentiating 6 cord from stromal tumor, as I said, that's one highway in my thinking, could be really, really very challenging. We will try to give you some tips today. Here is one tip, which is reticulin stain, because reticulin surrounds individual stromal cells. So individual fibroblasts in the stroma or theca cells will be surrounded by reticulin. But in granulosa cell tumors or in 6 cord tumors, reticulin surrounds groups of cells. So this is a very simple stain in your lab that can help you with that differential diagnosis. You can do a reticulin stain. If you see the stain surrounding individual cells, so that probably is a stromal tumor. If it surrounds group of cells, then that probably is a 6 cord tumor. Most likely that example is a granulosa cell tumor on your right. FOXL2 mutation is another tool that we have in the lab today. FOXL2 mutation was described in about more than 10 years ago or 12 years ago, and it was positive in 90% of adult granulosa cell tumors. Then after that, we started to realize that at first we thought that it can separate granulosa cell tumors from the rest of the 6 cord tumors. But now we realize that probably most 6 cord tumors will have some sort of FOXL2 mutation. And FOXL2 IHC corresponds very well with mutation, and it can even be positive without mutation. So the slide you see here on the IHC slide here is FOXL2 IHC, and this is a case of granulosa cell tumor. And I can tell you, we know that 90%, let us just say all granulosa cell tumors are going to be FOXL2 positive. In other words, if the case is FOXL2 negative, it cannot be granulosa cell tumor. I can say that much. Let me repeat that statement again. If a case is FOXL2 negative, then it cannot be granulosa cell tumor. But if it is positive, it could be granulosa cell tumor, but it could be thecoma, for example, or it could be other stromal tumors, but it will not be a carcinoma, for example. So again, going back to the two highways I was talking about, if your question in your mind, is it sex cord-stromal or carcinoma? I think FOXL2 will do a good job here, because we said that FOXL2 is positive in most sex cord-stromal tumors. So if your case comes back positive, then probably it's not a carcinoma. But FOXL2 is not going to help you when you drive on the other highway, because it doesn't separate granulosa cell from other sex cord-stromal tumors as well. So if that is the question on your mind on the right, then probably reticulin stain will help you. I hope I'm just clarifying the issue, because when you are faced with the case, all those questions are running in your mind, and try to organize your thoughts. What is the question you're asking, and what is the tool that you are going to use to answer the question? Here's the first example of stromal tumors, microcystic stromal tumor, young patient, solid, just it looks grossly like a fibroma, but you can see a lot of holes in the tissue. High power, you can see that there are microcysts. This is an easy diagnosis. It usually affects younger patient, can be seen in any patient, in any age. It's a benign tumor. So you can imagine that that tumor will stain positive for inhibin. It could even be, could even stain positive for FOXL2. Here's another example of another stromal tumor. You see diffuse proliferation of homogeneous cells. Nothing is fancy about them, but if you notice in the left upper corner, you start to see some holes, high power. Oh my God, they look like signet ring, of course, because it is a signet ring stromal tumor of the ovary. What is the differential diagnosis here? Of course, the differential diagnosis is a Krukenberg tumor, metastatic signet ring carcinoma of the stomach. That is a very different presentation. There's typically history. And frankly, Krukenberg will not look like that. This is too good to be Krukenberg. In Krukenberg, you will have signet ring here, signet ring there, but you will not see masses of signet ring as you see in the signet ring stromal tumor. Okay, let us take this group of stromal tumors together and lump them together because they look similar. On the far left, I will talk about stromal luteoma, and then there is the pregnancy luteoma, and then there is Leydig cell tumor, sex cord tumor, and then there is the steroid tumor. All right. Stromal luteoma is typically seen in perimenopausal patients. You will be presented with a very small tumor, less than 3 centimeters. And microscopically, you will see luteinized cells surrounded by theca cells. In other words, it occurs within the ovary itself, which is very different from this tumor here, which is Leydig cell tumor, which is also typically small, but it is present in the hilum. So when I will show you examples now, the first question you ask yourself when you see luteinized cells, am I in the stroma of the ovary, i.e., am I looking at stromal luteoma, or am I in the hilum of the ovary, i.e., I'm dealing with the Leydig cell tumor? Leydig cell tumors are androgenic, they secrete testosterone. So typically, you will get the history, the patient has hirsutism, and she has hair loss and whatnot. Pregnancy luteoma is just like stromal luteoma, but of course, you have the history of pregnancy. The patient is pregnant or was pregnant, which is very different from the entity known as steroid cell tumor. This tumor can be androgenic also, or could be can secrete any hormones. And this will look more like you are looking at adrenal gland tumor. This diagnosis is the only important diagnosis in all four because there is a malignant counterpart of steroid tumor. And here are the criteria of malignancy if you have a large tumor with hemorrhage and necrosis and whatnot. So when you deal with these tumors, your main focus is to separate Leydig cell from stromal leukemia and to separate them from steroid or lipid cell tumors. How about this example here? We have an ovary. We have some round collections of pink cells, multiple nodules, as you can see here. Look at these nodules. First of all, they are multiple. Second of all, they are all very small. They are microscopic. What are these cells? These are hilar cells, and we call that hilar cell hyperplasia. That is seen in postmenopausal patients due to the unopposed increase in FSH. So they get, again, these cells will be hyperplastic. They will secrete androgen. The patient will have hirsutism, but we don't call that a tumor because they are very microscopic and typically are multiple. I guarantee you, when you sign out any case of postmenopausal patient, if you look carefully in the hilum, you will see, and those of you who sign with me, I always point these out, you will see islands of hilar cell hyperplasia. All right, here we have a nodule of pink cells, and I will give you a high power now, but the low power is meant to show you where this nodule is located. You notice that it is located right in the cortex of the ovary. It is surrounded by blue theca cells all around it. So what would be your diagnosis? You will be here. You will be in the stromal leukemia that is surrounded by theca cells from all directions. Here it is high power, nuclei are round, monotonous, no mitosis, but the cytoplasm is pink and cells are cuboidal, very nicely separated from one another, which is very different from this tumor, which is also composed of groups of pink cells, but look where it is located. It is located in the hilum of the ovary. Hilum of the ovary. So what your diagnosis should be, it should be a Leydig cell tumor. Go back here, you are here now, because it is present in the ovarian hilum. So the difference between this stromal leukemia and this is basically, for diagnostic purposes, it is the location. This would be a Leydig cell tumor. Here's an example from our former fellow, Shannon Welter, gave us this case. You can see the nests of pink cells, nodular arrangement, high power. You see how the pink cytoplasm, a little bit granular because it has some hormone granules here, some brown pigmentation, and the nuclei are round. They are all monotonous. Look at the prominent nucleoli, a lot of RNA in these nuclei because in these cells, because they are forming steroids, they are very hormonally active. They are androgenic. You don't see mitosis. So what is your diagnosis here? My diagnosis should be Leydig cell tumor. Of course, I'm helped if the clinician tells me that the patient has hirsutism. All right, going back to our constitution here, we went through the list of pure stromal tumors, and I said pure stromal tumors are mostly benign if you exclude fibrosarcoma. So now we are going to move into the sex cord categories. And let us start by pointing out what I already said, that sex cord can differentiate into male or female differentiation or can be mixed. In the female, then we will have granulosa cell tumor, adult type, and we have the juvenile counterpart. If they differentiate into male, then we will have Sertoli cell tumor, which is typically seen in cases of Weisjager syndrome. But what you see here a lot, I would say every year we see a handful of them, of sex cord of Sertoli-Leydig cell tumors. And there is the gynandroblastoma, tumor of mixed male and female, and I mentioned that before. Okay, let us start from here. I will start with a granulosa cell tumor. Typically, granulosa cell tumors are presented to you as large hemorrhagic tumor, very necrotic. Why is it large? Because granulosa cells proliferate, and because they proliferate so fast, they exceed their blood supply, so they become necrotic. Look at the gross picture on the left and tell me if this is not concerning to you. And it was concerning to the gynecologist. So the gynecologist will come to you and say, hey, look at this ovarian cancer. This is cancer. Why is it cancer? Because it is large, it is hemorrhagic, it is necrotic, and because the patient has abnormal bleeding. And I will talk about that in a second. Calm down, take a deep breath. And your sections, again, remember the two highways? I'm asking myself, is it 6 cord-stromal tumor or a carcinoma? Well, the surgeon is telling me this is a carcinoma. I feel like I'm pressured to make a diagnosis of carcinoma. Take a deep breath and step back a little bit. You notice that the cells are arranged in groups. If you can notice those pink structures that we call exner bodies, I specifically gave you a low power here. I know that you are thinking now, I need a high power. No, I want you to look at this in low power, because this is what is going to save you on a frozen section. If you can spot exner bodies at the lowest possible power, then you are golden. This is not carcinoma, because I see exner bodies. I see pink structures with rosettes around them. Can you see that? Tell me you can see them. You can see pink with rosettes around them. Look at that. Look at that. Well, I can see some spaces as well, which is we call insular pattern of granulosa cell tumor. And I know you are a fan of high power. Okay, knock yourself out. Look at the high power. All right, you got your grooves. You got your nuclear grooves. You got something that looks very much like coffee beans. This is coffee beans. So as soon as you get the grooves in the nuclei, you can calm down now. Now you are dealing with a granulosa cell tumor. So granulosa cell tumor is a diagnosis of low power by exner bodies or high power by the nuclear grooves. I showed you an example of the insular pattern where granulosa cells separate from the stroma around them. And here's a difficult case, because in the diffuse pattern, cells can get a little bit luteinized. When granulosa cell luteinizes a little bit, they start to become pink, and cells start to be a little bit large. So look at this case, look at this slide now, and see how you can easily get confused now. What am I looking at here? Is this a thecoma? Is it a stromal tumor? Is it a sex cord tumor? Or is it even a carcinoma? So you start to doubt yourself a little bit. And here's another case. This is one of our file. It is scanned in your slide. You can see, again, a beautiful granulosa cell tumor. You have trabecular pattern. Cells, you can see the grooves. They look like coffee beans, but they have groups of pink cells in between. And these pink cells actually have bile in them. There's brown pigment in them. And that's an entity of granulosa cell tumor called granulosa cell tumor with hepatocytic differentiation. A rare tumor, but you will see it. Or if you look hard enough, you will see it. If you are not interested, you will miss them. And these cells are positive just like any hepatocyte differentiation, positive for arginase and positive for HEPAR1. So this is another trivia that may confuse you a little bit, but it is still within the spectrum of granulosa cell tumors. Granulosa cell tumors are estrogenic. So this patient has high estrogen levels. And what do you expect is happening in the endometrium? Of course, the endometrium has atypical hyperplasia or even adenocarcinoma. And that is why this patient had abnormal bleeding. You can see how now this case can be very scary on frozen section because you are presented with a large hemorrhagic tumor and the surgeon is telling you, oh, this is cancer, it grows fast and the patient has bleeding, blah, blah, blah. Well, again, yes, I know why she has bleeding. She has high estrogen and she has atypical endometrial hyperplasia. All right, this is a young patient with a relatively large but solid ovarian pelvic tumor. And on cut section, you can see again how it is fleshy, it is hemorrhagic, but you can also see the lobulation. It is lobulated. Remember, if this was a malignant germ cell tumor, it will be very friable. We will talk about that next week. I will bring this case back next week and I tell you the difference between, say, this and a dysgerminoma. So I'm looking at this young patient. I have a differential diagnosis. We will talk about that next week. But what I want to point out here for you is that the cut section is lobulated. It is hemorrhagic, but it is not friable. It is not friable. It's not falling apart. It is rather fleshy. When it feels just fleshy, almost like muscle. Microscopically, again, you can see low power. You can see the lobulation. And on high power on the right, you see lots of mitosis. Remember, juvenile granulosa cell tumor is not going to be coffee beans anymore. You are not going to see the nuclear grooves. You are not going to see the cold exoner bodies. You will see just a lot of cells with lots of proliferation, lots of mitosis. Okay, so now I am confused. So why isn't this cancer? Well, the good news that this is not cancer because the setting in which you are presented with the case is not one of cancer. This is a young patient. So you are already primed to think in a certain way. This is a tumor. What are my options if you give me this tumor and say this is a young patient, a young 13 or 18-year-old? What are my options? What are your options? Your options are either a juvenile granulosa cell tumor or maybe a dysgerminoma. We will talk about that next week. Guess what? You can do inhibin. So this case will be inhibin positive. End of story. You got your answer. So a fleshy cellular tumor in a young patient with lots of mitosis that is inhibin positive. Duh, what else could it be? Don't go to FOXL2 because juvenile granulosa cell tumors, unlike adult granulosa cell tumors, don't have the FOXL2 mutation. Again, juvenile granulosa cell tumor could be a little bit problematic when they are luteinized. Cells could be a little bit large. I want to point out this cavity here that could be seen in juvenile granulosa cell tumors, these holes in the tissue, and they could give us a problem. I will point the problem in a few minutes. But again, this is a high power of the juvenile granulosa cell tumor to show you the cellularity, not much in terms of grooves, but lots of mitosis. All right. Let us move to the next category of the male differentiation. And I'm presenting you with a very cellular tumor, cellular blue tumor, lots of cells, lots of proliferation. What is going on in your head now? Is it sex cord-stromal or is it carcinoma? I think we can get that. It is not carcinoma. So get out of that highway. Now you are in the other highway. So is it thecoma? Or is it sex cord, i.e. Sertoli? That should be your question. High power, yeah, I see cells are trying to arrange themselves in small cords. There is a little bit linear differentiation. Thecoma is not going to do that. That's more like sex cord arrangement. I start to think of Sertoli maybe. I cannot make a diagnosis of Sertoli. You cannot. You are forbidden. You are forbidden from making a diagnosis of Sertoli unless you see tubules. And I say this is a must. So if you get a tumor like this without tubules, but you think it could be Sertoli, what should you do? You go back to the bucket and submit more sections. And if you don't see tubules, get more sections. You keep getting more tissues until you get those small tubules. Aha, now the light bulb goes on. Now I'm dealing with a Sertoli. Of course, once you see tubules, you start to see them all over the place. You just need to know what you should be looking for. So I have blue cell tumor, very cellular, maybe a little bit of cords. I start to look for tubules. Once I see them, now I know I have a diagnosis. Now we are in the 6-cord category. And it will be nice if you can appreciate some Leydig cells entrapped in between. Yeah, nice. Leydig cells are always nice to find because it affirms the diagnosis of Sertoli Leydig cell tumors. Sertoli Leydig cell tumors could be well differentiated, moderately differentiated, or poorly differentiated. What I am showing you here is a very poorly, that is the extreme end of the poorly differentiated category. And in the poorly differentiated category, you can have heterologous components. And the heterologous component you have here is intestinal epithelium. So again, you don't see heterologous components with granulosa cells. You see them with Sertoli cells. So that's, again, another feature that confirms the diagnosis. So on the far left end of that spectrum, the very well-differentiated Sertoli Leydig tumor will be this example here, where everything is tubules. Unlike the previous one where we struggled to find the tubules, here everything is tubules. And the tubules can take all sorts of shapes: cystic spaces, small structures, large structures, branching tubules, retiform. You can have all sorts of forms, but in between the tubules, you will always find those beautiful, beautiful Leydig cells. So this will be a well-differentiated Sertoli Leydig cells. So Sertoli Leydig cells, again, comes in 3 flavors: well-differentiated, moderately differentiated, and poorly differentiated. Or you can look at the molecular classification of Sertoli Leydig cell tumors, which I guarantee will be on your board exam, because the first category is the DICER1 mutant tumors. That's the one you see in young patients. And that is the one case actually I just showed you with heterologous components. You see that in young patients, typically poorly differentiated or moderately differentiated. And that will be considered as a malignant tumor. Patients should be tested for DICER1 mutation. On the extreme end of that, you have the FOXL2 mutant Sertoli Leydig cell tumors, which is seen in older patients, and again, will be grade 2 or 3, but it doesn't come with heterologous components. So you may want to test for FOXL2. We don't have the stain here in our institution. We will get it hopefully soon, but we would need to test for FOXL2, and the patient needs to be tested for FOXL2 mutation. And of course, you have the wild type category, which is the majority of tumors. These are seen in middle age, and these are the case. This is the case. This case was well differentiated, and it was wild DICER and FOXL2. All right, so again, I'm going back to my 2 highways here, and I want to mention some immunostains, not because we love immunostains, just keep throwing antibodies on your tumor. No, you have to ask yourself a question. What is your question? My question is it 6-cord-stromal or is it carcinoma? I am on this highway here, this highway. What would you do? Inhibin will help you. I showed you FOXL2 will help you. But inhibin and FOXL2, nothing helps you separating Sertoli Leydig from granulosa cell tumor. Nothing, because they stayed the same. They are just, it's the same tumor. One is male and one is female. Remember this, don't use immunostains for the second highway. The second highway is pure morphology. The immunostains are used for the first highway if you are separating them as a group from carcinoma. I hope I'm very clear on that. And there's this sweet tumor that has lobules of cells but these cells are arranged in small cystic spaces, and the cystic spaces have some basal lamina material. I apologize for the quality of the slide because this is a very old case of mine from the Armed Forces Institute. It is scanned, it's in your box. These tumors are so rare that we can't find good examples, but SCTAT, 6 cord-stromal tumors with annular tubules, are round rosettes with basal lamina material inside. Why is that tumor important? It is important because it comes in two forms. One form with syndromic Peutz-Jeghers syndrome. We have an example here in this institution a few years ago. And these are typically very small tumors, bilateral, and they are usually multifocal. You see them all over the place. And the surgeon knows it, the patient knows it. The patient has Peutz-Jeghers, and the patient has an ovarian tumor. They take it out, typically with calcification. You see solid proliferation. Sometimes don't be scared because you will find the basal lamina and you will make a diagnosis of SCTAT in a Peutz-Jeghers syndrome. However, the other form of this tumor could be large. It's a solid single tumor, and that tumor is important to recognize because that tumor may recur or may transform into a granulosa cell or a Sertoli Leydig cell. So separating SCTAT syndromic from non-syndromic, in my mind, is very important. It's not difficult. Syndromic are small, focal, microscopic, and the patient knows it. And the non-syndromic are large. And the differential diagnosis could be granulosa cell tumor, if you think these could be called external bodies. So again, no immunostain is going to help you because both tumors will be inhibin positive. That's not how we differentiate them from each other. I want to finish with this bizarre tumor that is called small cell carcinoma with hypercalcemia. It is included in this category because we don't know where to put it. So it is included with the 6 cord-stromal tumors, but it is not 6 cord-stromal, and it is a misnomer at all levels. It is called small cell carcinoma with hypercalcemia. Cells may not be small, so it's not small cell. But it has nothing to do with your neuroendocrine small cell carcinoma of the lung, because that just aggravates me so much when I see people trying to make a diagnosis of small cell carcinoma with hypercalcemia. So they order synaptophysin and chromogranin. Just because the name is small cell, they say, well, yeah, so that's chromogranin. No. Synaptophysin and chromogranin have no room here in this tumor. Frankly, we don't even think it is a carcinoma because cells might not be even epithelial, and only 1/3 of them will have hypercalcemia. So why do we call it hypercalcemic? I don't know. So this tumor but you need to know this tumor because it affects young patients. Aha, so this is another tumor in young patients. So we mentioned the differential diagnosis in young patients includes juvenile granulosa cell tumors, dysgerminoma, which is a germ cell tumor, but it also includes small cell carcinoma with hypercalcemia. Typically unilateral, typically very aggressive. Patient presents with ascites. These patients don't do well at all. The cells may have rhabdoid appearance. They may get some mucinous elements, glands, but these tumors are SMARCA4 mutant, and if you stain for BRG1, they will be negative because they lost the staining. So I think this is why we started to think of these tumors as really belong to rhabdoid tumor category rather than the name of carcinoma. So the tumor will present to you like this: blue tumor, very cellular, but it has holes. Look at the holes in the tissue. Aha. So now I mentioned holes before. Remember that case of juvenile granulosa cell tumor? It had a hole, and I told you that hole is important because it will confuse me. This is how it confuses me. Both tumors are in young patients. Both tumors are very cellular. Both tumors may have ascites, and both tumors may have holes. So how am I going to differentiate them? Again, remember, this is not going to be inhibin positive. This is a situation where inhibin stain could help you. And this tumor, as I said, unfortunately, the presentation is very, very classic, very aggressive, way more aggressive than juvenile granulosa cell tumor. You will be presented with this tumor, and the surgeon will tell you the patient is not doing very well, has ascites, and as I said, most patients don't even make it within a year. This is a picture from the WHO book, again, to highlight the holes, but more importantly, it highlights the mitosis, and it highlights the high cellularity. Again, high power to show you the high cellularity, the convoluted nuclei, but this looks nothing like anything else we showed today. Again, if you send it for BRG1 stain, comes back negative, boom, you got your diagnosis. So that's how these tumors are diagnosed today. So we did it. We did it under 1 hour. 6 cord-stromal tumors are morphologically diverse, and that's why they are problematic. They have several overlapping microscopic features. 6 cord tumors will recur. 6 cord tumors, granulosa cell, Sertoli cell, or Sertoli-Leidig cell, or even sketat, will recur, and they will need to be managed aggressively. And they may acquire female, i.e. granulosa cell tumor, or male, i.e. Sertoli-Leidig lineage of differentiation. Stromal tumors are easy. They are benign. The thecoma, fibroma, signet ring stromal tumor, sclerosing tumor, all of these tumors, once you get your head in that category, you will be safe. As I said, the challenge sometimes is to separate 6 cord from stroma. The second highway could be challenging. To separate thecoma from a granulosa cell tumor, that could be a challenge. Thank you all for your attendance, and I hope this lecture helps you in your study and in your diagnosis. Any questions?